To our October Teach Educational Rounds. Here with us today, we have Carly Whitmore and Jennifer Marttila, who will be presenting on technology-enabled collaborative care for diabetes management, and particularly participant and provider experience of an integrated care model. And so we're going to get started with KMH's land acknowledgement. KMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We'll create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now, I'll invite everyone to introduce themselves in the chat and let us know which traditional territory you're joining us from today. If you're not sure, I can put the chat or the link in the chat there for you to find out. And you're also welcome to share something that you're doing to learn or improve your commitment to reconciliation. While you share that, I'll also just share a little bit about my positionality here. So like KMH, I am currently located on the lands of the Mississaugas of the Credit. I am a third-generation Canadian. In 1958, my grandparents arrived on a boat from Italy, and I actually grew up in Aurora with my two siblings. And then last year, I moved to the west end of Toronto, where I have grown to truly appreciate the community and the vibrancy that this land has to offer. I acknowledge the privilege I have as a white settler to live here, and specifically as someone living with type 1 diabetes, I'm particularly grateful to have access to insulin and all my other required medical supplies. So I myself am committed to reconciliation. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard and reflected within my work and personal life. So thank you for sharing, everyone else. Awesome. There's another person with diabetes in the audience, which is awesome. So I'm going to keep going for now, but please do keep sharing in the chat while I do so. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you registered for the webinar, completed the pre-learning assessment. As well, make sure you signed into the webinar using your full first name and last name so we can track your participation. And lastly, make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow. And you'll have 1 week to complete that. Along with that, you'll also be receiving these slides as well as the recording to review or share with any colleagues. And so here's a little bit more information on our presenters today. So first up, we have Jennifer Marttila, who is a registered nurse and certified diabetes educator. And specifically, she has served as the care coach for the TECD study, which you'll be learning about momentarily. Jen has also lived with type 1 diabetes for over 25 years and relates to both the triumphs and challenges that living with diabetes can bring. So welcome, Jennifer. We also have Carly Whitmore, who is also a registered nurse and a postdoctoral fellow in the nicotine dependence service here at KMH. And one of her main research interests include optimizing care to support mental health and chronic disease management. So welcome, Dr. Whitmore. So, and no disclosures from them to report. And please know that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat throughout the webinar to post any comments or answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel, And just ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. Also, just a note that we will have a dedicated question and answer period at the end of the presentation. So feel free to keep note of anything that comes up and post it in the chat during our Q&A period for our presenters to answer. And you're also very welcome to send a reaction if you would like. So send a thumbs up or clapping hands or anything throughout the webinar, just like that. Yeah, so you're welcome to do that. So with that, I'll hand it off to our presenters to take it away. Thank you, everyone, and enjoy the webinar.
Thanks, Natalie, and hello, everyone. Jen and I have been looking forward to today for quite some time. We're excited to not only share some of the findings from the Technology-Enabled Collaborative Care for Diabetes Management, or the TECD study, as we'll be referring to it, but also to provide an update for some of you who may have attended the webinar that was hosted earlier this year on the same topic. So over the next 40 minutes or so, we will discuss the relationship between diabetes and other health risk behaviors that include smoking. We'll present an overview of the TECD virtual model, which was a co-redesign study to support individuals who live with diabetes, mental health challenges, and tobacco addiction. And we will also be describing the experience of individuals and providers who participated in the TECD feasibility study. But before we do that, and building on what Natalie shared earlier, it's important for Jen and I to position ourselves within our relations as community members and as registered nurses. So collectively, we are daughters, a mother, aunts, partners, and settlers with genealogical ties to England, Ireland, Scotland, and Poland. Both of us, as third-generation Canadians, our families have benefited from the lands and resources that were stolen from the First Nations who cared for them for millennia before us. Joining this webinar today, and along with our connections to McMaster University, Jen and I acknowledge and honor that we're located on the traditional territories of the Mississauga and Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. The symbolism of the dish with one spoon wampum is that you never take more than you need, and you always make sure that there's something left for the next person. As registered nurses and health researchers, we carry the weight of this knowledge, especially in understanding our role and power in decolonizing a medical system that continues to do harm. Today, Jen and I are talking about diabetes and mental health, and we understand that there is a disproportionate impact of these conditions on First Nations, Inuit, and Métis, as a direct result of colonialism and forced separation. We are committed to enacting culturally safe, anti-racist research, practice, and education that address these inequities. And we're humbled by the opportunities we've had to learn and grow, and continue to seek out to further our education and engage in further dialogue. In March of this year, colleagues Ikra and Dr. Osnat Melamed presented on the TECD model. They shared information about the relationship between smoking and diabetes. They shared important context on the ways in which the COVID pandemic additionally challenged individuals who were living with diabetes as they try to manage their health and healthcare needs. And further, they provided an overview of the TEC model and the ways that it can provide management support for diabetes, mental health, and tobacco addiction. We won't be repeating this information, and so if you missed this presentation, and if it's of interest to you, feel free to reach out or visit the Teach webinar website, where a recording of the presentations are available. At the time of this presentation by our colleagues back in March, the TECD project was still recruiting participants, and so Jen and I are excited to share findings from this study today.
There are several health risk behaviors known to contribute to the development of type 2 diabetes. These include smoking, alcohol consumption, stress, poor diet, sleep, and lack of exercise. The previous webinar from our colleagues described the well-established relationship between smoking and diabetes. Today, I will briefly highlight how smoking and these other health risk behaviors is one we think our virtual care model can address. There's an extensive body of literature reporting on the association between smoking and the incidence of diabetes. Smoking is an independent risk factor for diabetes, with a 44% increase in smokers compared to non-smokers, and as such should be considered an important modifiable risk factor for developing type 2 diabetes. The literature has demonstrated the existence of a dose-dependent relationship with a higher risk of diabetes seen in heavy smokers. For those who have diabetes, smoking makes diabetes more difficult to manage and significantly increases the risk for serious health complications. Smoking cessation improves insulin sensitivity despite possible short-term weight gain, and over time can improve blood lipid levels regardless of any weight gain associated with stopping smoking. The same approach to alcohol consumption that applies to the general population can also apply with diabetes, as the occasional consumption of alcohol does not generally worsen blood sugar control. However, chronic heavy consumption of alcohol, defined as greater than 21 standard drinks per week for men and greater than 14 standard drinks per week for women, is associated with increased risk for cardiovascular disease, microvascular complications, and all-cause mortality in people with type 2 diabetes. Substance use disorders may contribute to unique challenges in this population as well. While the exact prevalence of substance use disorders in people with diabetes is not well established, recreational substance abuse is associated with increased rates of hospitalization and readmissions for diabetic ketoacidosis. Substance abuse and psychosis among individuals with both type 1 and type 2 diabetes increase the risk of all-cause mortality. Research has shown an increasingly clear relationship between diabetes and a variety of mental health issues. These include diagnosable psychiatric disorders and other problems that are specific to the experience of living with diabetes. A wide range of psychiatric disorders, including major depressive disorder, bipolar and related disorders, schizophrenia spectrum, and other psychotic disorders, anxiety, sleep, eating, and stress-related disorders are all more prevalent in people with diabetes compared to the general population. Diabetes distress refers to the negative emotions and burden of self-management related to living with diabetes. This term is used to describe the despondency and emotional turmoil specifically related to living with diabetes. In particular, the need for continual monitoring and treatment persist. Concerns about complications and potential erosion of personal and professional relationships. The presence of psychiatric and diabetes-specific psychosocial issues is associated with a reduced participation in self-management activities and can lead to a decrease in quality of life. Psychiatric disorders among individuals with diabetes increases the risk for diabetes complications and early mortality. Additionally, a history of trauma, post-traumatic stress disorder, and subsyndromal traumatic stress contribute to a higher risk of diabetes. It has been found that people with both types of diabetes have increased rates of suicidal ideation, suicide attempts, and completed suicide compared to the general population. Similarly, people with type 2 diabetes that is newly diagnosed had a rate of past suicide attempts of almost 10%, which is twice the rate in the estimated of the general population. The rate of past suicide attempts in currently depressed patients with diabetes was reported at over 20%. Obesity, especially abdominal obesity, increases the risk of developing type 2 diabetes, and it is known that 80 to 90% of people with type 2 diabetes have obesity. Dietary patterns characterized by higher intake of red meat, processed meat, French fries, refined grains, eggs, and high-fat dairy products were also associated with a higher incidence of type 2 diabetes. It is recommended that diabetes education programs serving vulnerable populations should evaluate the presence of barriers to healthy eating, for example, the cost of food and stress-related overeating, and work towards solutions to facilitate behavior change. There are many healthy dietary patterns that may be considered for people with type 2 diabetes. However, all approaches should always incorporate individual nutritional preferences. Sedentary behavior is associated with adverse health outcomes, even after statistically adjusting for levels of moderate to vigorous exercise. It has been shown that high levels of total sedentary behavior and television viewing were associated with overweight, obesity, and type 2 diabetes. For this reason, it is suggested that physical activity levels and sedentary behaviors be considered distinct and potentially independent behaviors. Physical activity can help people with diabetes achieve a variety of goals, including cardiorespiratory fitness, increased vigor, improved glycemic control, decreased insulin resistance, improved lipids, blood pressure, and a maintenance of weight loss. Supervised exercise interventions have been found to improve A1C, triglycerides, and cholesterol in people with type 2 diabetes, and may also reduce the need for medications and contribute to weight loss. Short sleep duration, defined as less than 4.5 to 6 hours a night, was also associated with higher A1C levels and fasting plasma glucose levels. And that's compared to the typical duration of sleep defined as 6 to 8 hours a night. Interestingly, long sleep duration defined as more than 8 to 9 hours a night may also be associated with higher A1C and fasting plasma glucose levels. Poor sleep quality was associated with higher A1C. Those with sleep apnea develop diabetes at higher rates than those without the condition, and better sleep quality is associated with healthy diets.
So, of course, this is not extensive review of the literature that speaks to each of the ways that these health risk behaviors, or the ways that each of them are contributing to the development of diabetes or the exacerbation of existing diabetes, or even how they contribute to further diabetes complications. But what we can see when we're looking at all of these health risk behaviors is a pattern emerging of a network or a web of how these behaviors are related to one another, and not just how they're related to diabetes. And so then again, this is by no means extensive, but instead meant to be illustrative of the interconnectedness or the complexity of these behaviors. Interestingly, and of particular importance for our work, is that these same behavioral factors also contribute to the development of or exacerbate existing mental health challenges, issues, or in some cases, even illnesses. And so when we consider these overlapping health behaviors, it brings to light the need for integrated mental and physical health care at multiple levels. It also showcases the broad range of skills, experiences, and knowledge that is required to adequately and fulsomely treat, educate, and support those who are living with diabetes and mental health challenges. So the need or the emphasis on integrated care, so this idea of bringing together clinical, personal, systems level resources, supports, and care isn't new, but it does present fairly unique challenges. And for those living with diabetes and mental health challenges, including tobacco addiction, to understand these challenges and to seek strategies to overcome them, there was a need for us to bring together individuals who understood this best. And so over the next few slides, I'm going to share an overview of our co-redesigned virtual care model, the TechD model, and how it can support management of diabetes, mental health, and tobacco addiction. So for individuals who live with diabetes and mental health challenges, this can include anxiety, depression, addiction. Their care typically is delivered not only across different care providers, but often in different care settings, with little to no communication between these providers or settings. So this problem is often referred to as siloed care, and it's particularly important when we consider the demonstrated interconnectedness of those health risk behaviors that we just highlighted. When we also consider that there's this perfect storm that the COVID pandemic brought in, where we had not only individuals living with limited access to interprofessional diabetes education, care, and follow-up, they were also living with limited support for their comorbidities, such as distress or depression, which may have been exacerbated during the pandemic. We also had this additional challenge of the rapid digitalization or mass shift to virtual care. And so this mass shift to virtual care brought about some existing or enunciated some further challenges specific to disparities, such as those who are living in digital poverty or with decreased digital literacy. The other challenge was that there was, and because of this mass shift, a seeming desire to replicate the siloed approaches that already existed prior to the pandemic. And so this challenge really did present us with an opportunity, but one that required co-redesign to imagine how virtual diabetes and mental health care could be delivered. And so by now you've heard me say co-redesign a few times, but what does that mean? What does that involve? Who? And I'm very glad that you asked. So the tech model, first applied in the Tech Y study, is pictured here on the left of your screen. The Tech Y, or the Tech E study, was a co-design intervention to support youth living with first episode or early psychosis. The model included a case manager who, using real-time data, provided education and support to youth. And this was supported by a virtual care team. The findings for this paper actually were just published, so I've included the title here for your review. Building on the success of this work and in knowing that there was an opportunity to better support individuals living with diabetes and mental health challenges, it was clear that the tech model itself provided the necessary base ingredients for our study population too. So this included keeping that individual in their context front and center, the use of a centralized point person to deliver education and consultation, the collection of key data, and this inclusion of a virtual care team of specialists, which Jen will talk more about. With the support of 3 persons with lived experience and our expert co-investigator team, we redesigned this co-design model to suit the needs of this population while maintaining flexibility for each individual. In some ways, I actually think this process may be more appropriately described as a co-design, but that's probably a bit too pedantic. So co-redesign was operationalized for us as this iterative process that included the co-design. And this approach was agile with a focus on building on existing assets, which I'll touch on in a moment. It is important to note that small changes were made throughout the study, both to the process of how the model was delivered, so things like the flexibility for each participant, as well as to what was delivered based on individual need, health team member expertise, etc. So these small changes, or sprints as they refer to them in the business world, were made to keep the individual at the center of the work being done. And they were facilitated through weekly design meetings with a small group of co-investigators and the staff team. This included our care coach, Jen, who would keep the design team up to date on participant needs, what was working, what wasn't working, and really provide those excellent strategies for change. So as a result of co-design and then this co-redesign, the Tech D model was established. We built on key assets, and this included the tech model itself used in the Tech Y study. And so, as mentioned, the elements of that original study were present in our iteration. But what we wanted to highlight here is that often when we think about virtual models of care, we think about slick and sophisticated technology. But for our study, and in the Tech E study, RedCap, a secure web application for building and managing online surveys, and WebEx Teams, a widely available web conferencing solution, made up the full suite of technology that was relied upon. Both of these programs are widely used and likely available to you at your various institutions. The second asset that we built upon in this co-redesign piece was building on one of our lead investigators' work. And so the Tech D model includes the use of a health coach. This health coach in our study was a certified diabetes educator and was the all-knowing, all-seeing, all-guiding health professional expert delivering the intervention. But we'll speak more about that. And then the third asset was we built on the STOP program. So you're all familiar with STOP, that's why we're here. And what we did was we leveraged STOP to purposefully sample individuals with mental health issues or challenges and diabetes for the study. This allowed us to access what may be considered a hard to reach population with ease. And it also, of interest here to our group today, meant that each of the participants in our study smoked, and this introduced some interesting opportunities as well.
Research supports that depressive symptoms, adherence to both antidepressant and non-insulin antihyperglycemic medications, and glycemic control are all improved when collaborative care is delivered by interprofessional teams for individuals with diabetes and depression. So in our model, the health coach was the key facilitator of this collaborative care. The health coach is an educator who encourages behavior change and provides psychosocial support. The health coach can also serve as a navigator and a translator, if you will, of our complex healthcare system. Behind the coach is the virtual care team. They provide expert support really for the coach. Our team consisted of a psychiatrist, a registered dietitian, an addiction specialist, a psychotherapist, and a peer mentor. Each team member brought a diverse and rich knowledge base that contributed to serving as an immense resource for the participant and helping to build capacity for the health coach. Their expertise was reflective of the factors that contribute to the development challenges and comorbidities of type 2 diabetes. As part of our redesign approach, we decided our intervention would consist of 8 sessions delivered weekly, with the flexibility to extend these sessions over a maximum of 12 weeks. This flexibility allowed for the makeup of missed sessions or extended support based on certain participants' needs. As Carly mentioned, we use the WebEx platform for phone or video-based communication according to the participant's preference. The first session with the coach was usually somewhere between about 45 and 60 minutes and included an overview of the coach's role, a health assessment, and an introduction to agenda mapping related to the participants' preferences. In our study, the health coach was a health professional, a registered nurse, and certified diabetes educator. The follow-up sessions were usually somewhere between 20 and 45 minutes long and generally included discussions about health education, behavior change, and they often included smoking cessation and psychosocial supports. A health coach can be defined as a health professional that facilitates the achievement of participants' well-being by enhancing self-efficacy, increasing motivation, and promoting problem solving. Based on the work of lead investigator Dr. Diana Sharafali, our coaching model involved case management and monitoring, self-management education and support, goal setting for behavior change, and psychosocial supports. Diabetes coaching is emerging as a promising self-management support intervention that offers personalization and is tailored to an individual's self-management needs and preferences. The dynamic nature of diabetes and its impact on multiple aspects of one's life requires individuals to make frequent and ongoing self-management decisions. It has been recommended that efforts to promote well-being and mitigate distress should be incorporated into diabetes management for all individuals. Motivational interventions, coping skills, self-efficacy enhancement, stress management, and family interventions have all been shown to be helpful. To date, a growing body of research evidence indicates that the combination of both self-management education and self-management support is most advantageous for improving glycemic control, self-efficacy, self-care behaviors, and reducing diabetes distress and foot complications. In the management of type 2 diabetes, the addition of health coaching to other activities of diabetes healthcare providers has been highlighted to improve glycemic control, self-efficacy, quality of life, medication or treatment adherence, behavior change, and also reduces healthcare utilization and cost.
Great. So while there is growing evidence to support the role of health coaches in diabetes care and management, health coaching in the mental health space is wading into newer territory. And so for this reason, our study objectives were to first assess the feasibility of the Tech D program, looking at things like recruitment, participant engagement, and how the elements of the program were implemented. And then second, to understand participant and provider experience and satisfaction with this model. So to do this, we aim to recruit 30 participants in order to complete that 8-week program. So this brings us to the third and final objective, which is to share that experience data with all of you. Hopefully this is what you're all here for. So to evaluate the feasibility study, quantitative data came to us through participants completing health questionnaires, and they did this at baseline, 4 weeks, 8 weeks, and 12 weeks. Participants were able to choose what tools or surveys they answered in the questionnaires. So that brought some interesting data to us as well. As well, of the participants who completed the study, each were invited to participate in a one-on-one interview. Of the 26 participants who completed the intervention, 11 of them agreed to this interview. I also completed 5 interviews with the provider team. And so the information shared here comes from both participants and our providers that were on the virtual care team. So across participants, engagement with the model was quite positive. Overall, we had a pretty even split of men and women. So about 15 of our participants identified as female. The mean age was 57 years, with our youngest participant in their late 30s and our oldest participant in their mid 70s. Interestingly, when we looked at this data, we came to see that our sample, our population sample, was quite well educated, with the majority of participants reporting at least some college or university, but interestingly, not working. We also saw a lower household income for our participants, which, taken in consideration with employment status and education level, might warrant some further investigation. Of interest too for us was that the mean years of having lived with diabetes was 9 years. And so participants were coming into this study seeking further help for their diabetes despite having almost had the condition for up to a decade. The majority of our participants were not currently using insulin. However, 61% of the participants reported that they either had concern with their medication or health supplies, and this was specific to how they would acquire the supplies or how they would afford the supplies. Overall, of the 31 participants that we did recruit, 5 of them dropped out. On average, participants stayed in the program for 7 weeks and completed about 6 of the planned 8 visits. On average, the visits lasted 38 minutes, which we think speaks to the depth of discussion that was taking place. Of interest to our team was that 11 participants participated only by phone. 7 participated using WebEx, and 9 through a combination of both, although usually this was, initially using WebEx, some sort of technological issues occurring, and then switching to telephone for the remainder of the intervention. When we revisit that coaching model that Jen walked us through and review the documentation, we see that each of the coaching strategies were employed throughout the visits. So across all of the visits with the 31 participants, strategies specific to behavioral change or modification were used 87 times. So on average, this comes out to about 3 times per participant. Strategies specific to case management were used 76 times. Case management and monitoring I'll get into that. The self-management 82 times, psychosocial support 111 times. When we look into this a little bit further, what we see is that on average, each of these strategies, when used with a participant, were used multiple times, so 3 to 4 times per person. So this wasn't a one shot and done type process. So on this slide, I've just included a few examples of what each of these strategies could include. So for example, with behavior modification, recommendations specific to smoking cessation or diet were included. I do think it's important to note here that these strategies and the related recommendations were not mutually exclusive, meaning that something like medication adherence could easily fall into psychosocial support, case management, multiple of the strategies. Okay. So a big piece of our study was the evaluation of the model and how participants experienced the model. And this was done through those one-on-one interviews. I had the privilege of completing 11 interviews with participants after they had completed the study. And I say it's a privilege because for any of us who complete qualitative research, we know that there is such power in being a part of and hearing people's stories, especially when it comes to their health. So our questions in these interviews were largely about the model, the intervention. However, we were interested in how participants viewed the program in the context of their own health, their health experiences, and their needs. So when talking about mental health, often conversation circles around this idea of stigma or shame of having mental illness. But there's also growing literature that speaks to the ways that shame manifests in people who live with diabetes. And for many, this shame actually can create distress. So when talking to one participant, when I asked if they had ever felt shame regarding their diabetes, they said, "For the longest time, I would avoid restaurants. I was angry. I've come to terms with the fact that, this is what it is, and I have to live around it." I think this is such a powerful quote for our discussion here today because it captures that for so many people, there's a daily grind that comes with living with diabetes. And the mental toll that this condition can take is heavy. So the burden of this condition to this participant, sorry. Okay, I'm going to go to the Sorry, I lost my place in my notes. Here we are. Okay, so concerning the model itself, participants felt that virtual care was practical and effective. Participants valued not having to manage the challenges of in-person appointments for their care needs. And I'm sure many of us have had these similar conversations over the last couple of years, especially considering the COVID pandemic. Participants were highly satisfied with the model. They described the expertise of the care coach as over and above what they otherwise had access to. And this was especially interesting when we consider that some of the participants were active patients of diabetes care teams in their home communities. Participants also appreciated the flexibility of the program. So this meant that for some participants, they completed 8 visits in 8 weeks, others completed 6 in 8 weeks, and for a few, based on need, they completed their visits over the course of 12 weeks. For participants, this was valued, and in the interview, some participants expressed a wish for the program to be longer, while others felt that the duration was just right. So we've got a Goldilocks question on our hands. Many participants did wish for follow-up or a more gradual discharge with the opportunity for additional touch points further out than the 8 weeks. And in talking with our care team, this sort of tension or end was also discussed. Finally, participants noted and appreciated the clinical integration, meaning that integration of physical and mental health care. They felt it was that sort of one-stop shop program. And as we discussed earlier, they recognized that current models actually silo their health. Participants expressed that this was missing from their traditional diabetes care. And for one participant, they actually felt that in having this all together, they felt that they were finally recognized as more than just the sum of their parts. And so I could take some time and walk through each of these points in the literature and the current gaps in the literature specific to these findings, or share how all of this comes together. But instead, I actually think one of the study participants, in my opinion, did this better than I ever could. So it never felt like we were doing anything really structured. It was like having a chat with a friend, but that friend had all this knowledge and this team of specialists to support her. It didn't feel like she was following an itinerary or that she had specific steps to follow. It was organic and specific to me, and I think that's why I was able to make some big changes for both my physical and mental health, changes I've needed to make for many, many years. The flexibility of the program, the person-centeredness, the clinical integration, and importantly, that self-efficacy, the behavior change, also beautifully captured here. I'll now pass it over to Jen to talk more about the provider experience of delivering this care model, and more specifically, some of her reflections as the care coach.
Thanks, Carly. Historically, in diabetes programs across the country, self-management support has been delivered by diabetes educators. Interestingly, my educator colleagues and I are challenged to offer frequent, ongoing, supportive follow-up and case management due to our expanding caseloads, the complexity of individual diabetes care, and limited time and resources. Unfortunately, patients often turn to other avenues for support that may not always be effective. For example, seeking care from non-specialized healthcare providers may not be efficient, like an appointment with a primary care provider or emergency hospital visit when in crisis, or evidence-based, for example, seeking information from unreliable websites. We know that the evidence indicates that health coaching supports individuals by enhancing self-efficacy, reducing real or perceived barriers, improving problem-solving skills, supporting patient-driven goals, and offering tailored feedback and support. As Carly mentioned, part of our study was to explore the experiences of the health coach and the virtual team. So participation in this project was my first experience as a health coach. Going in, I assumed it would be very much the same as my day-to-day practice, as I felt I already incorporated many of the same skills, such as motivational interviewing. I was concerned, though, that many pieces were missing. I had no referral form, medical history, hospital consult note, lab work, or medication list. Of course, I was already finding myself in that educator mindset, formulating my agenda even before the first interaction. So after my first interaction with a participant in the study, I also wondered if the open agenda of health coaching was maybe too oversimplified when caring for patients with diabetes and such complex health needs. I asked myself, how could a 20-minute interaction be enough to cover everything needed? I also felt intimidated by some of my learning gaps regarding experience caring for people with severe mental health diagnoses and addiction challenges. However, this vulnerability forced me to step back and listen to what the participant wanted and valued at that particular time in their health journey. We've chosen this image of parachuting for a reason. I imagined myself dropping into the participant's life at that particular moment, not having any preconceived ideas, allowed an organic relationship to form. I was able to help them articulate what was meaningful to them at that time rather than what I felt they needed. My first meeting with the virtual care team quickly brought discomfort to ease. I was able to receive education and coaching too. So I would say, the virtual team is coaching for the coach. We reserved a 1-hour weekly meeting time for the virtual care team to come together. The frequency of the meetings was based on my needs as a coach, of course, which often directly tied to the needs of the participants. During those meetings, I usually led the conversation by presenting a profile of the participant. I was able to share a link to my session notes, which were stored on RedCap for the group to review if desired. The meetings really did help to expand my knowledge and confidence. Each member of the team offered different approaches and perspectives, often things I may not have otherwise thought of. Everyone brought their unique experience to the table. My capacity as a registered nurse and diabetes educator was greatly enhanced by the virtual care team. For example, I learned how to connect better with clients that had severe mental health needs. I'm now better equipped to support someone during an episode of severe anxiety, and I feel much less intimidated when responding to someone with suicidal thoughts. One area in which my capacity has grown significantly is discussing smoking cessation with patients. I always knew it was very important to talk about smoking cessation. Of course, we highlighted some of those concerns earlier, but this experience, I learned so much more, how to explain the pathophysiology of smoking so that my clients actually had a deeper understanding, specific behavior change methods that were used unique to smoking. Also gained a wealth of knowledge about nicotine replacement therapy. I was able to bring all of that knowledge back to my daily practice. And honestly, it's been so satisfying to see several patients in my care outside of this project succeed in their journey to smoking cessation. Throughout this experience, my capacity as a diabetes nurse educator was enriched related to the accessibility and the learning from the virtual care team. Like I said, they indeed were my coaches. This speaks to the value of this integrated model for both patients and providers. So not only do patients have access through the coach to a more tailored patient-centered approach, but the provider is constantly learning too. In summary, I view my role as a health coach as one who meets people where they're at, which means not having my own agenda. Understanding the behavior change is guided by the participant and supported by the coach. Assisting patients in establishing a focus for the visits, assisting in the formulation of health-related goals, and providing what we call just-in-time health education and problem-solving support. So what does this mean for the future? As this study was a feasibility study and not a full-scale trial, we really do have so many opportunities in front of us. In talking with participants, providers, and more recently, clinicians in the primary and community care sphere, we clearly see that there is not only a need for this model, but an appetite. So what comes next? As a team, we're more excited than ever. We want to move this model, and we believe that there is a real need for integrated and collaborative program. We have been wondering and discussing many things, including process and implementation pieces, such as duration, frequency of follow-up, offboarding. We also have been pondering how this model may be especially relevant in rural and remote applications, considering the waitlist and limited access to diabetes and mental health services. With that said, we're curious how this model, such as a model such as this, supplements existing care. For example, as we already mentioned, a few participants in this study were connected and actively serviced by diabetes education programs, just like the one that I work at. And yet these participants, like the quote we shared earlier, still saw great value in this model. Another question pondered is who the care coach should be. In the TechWise study, the care coach was not a regulated healthcare provider, but someone with relevant knowledge, skill, characteristics, and attributes. In this TechD model, I'm a registered nurse and certified diabetes educator. We wonder if this work could be done with someone who is not a certified diabetes educator. Could it be another registered health professional or someone who is not a regulated care provider, like a peer support or community health worker? Currently, the training and regulatory requirements for health coaches have not been clarified, and significant variations in the scope of practice for health coaches remains in the Canadian healthcare setting. We're curious about your thoughts for the future too, and we hope you can share some of these in the chat or during our question period.
We would be remiss to not say how grateful we are not only to our funders, but also the institutions that have granted this opportunity to us. Special thanks especially to the principal investigators, Dr. Peter Selby, Dr. Diana Sharafali, and Dr. Farouk Naeem. Working with this team really is the dream as an early career scientist myself, and Jen and I have valued the opportunity to grow, contribute, and learn under this leadership. We are also very grateful to the broader TechD study team, including those in the nicotine dependence service, Rosa, Erica, Elise, Osnat, Ikra, Lankra, and the persons with lived experience who contributed so much, Frank, Sita, and Gloria. We thank you for your insights, guidance, and expertise, and we're really excited to see where this project goes. And we hope that you all might be excited too. So here are our references. If there's something that particularly stood out to you, please feel free to connect with us via email. Happy to share. Of course, there's 2 pages. And we'll open it up to questions. Great. Okay, so I'm seeing some good questions in the chat. Maybe I'll start there. Is that okay, Natalie? Okay.
Go for it, yeah.
Okay. So one of the questions I had sent to me was how long was the initial outreach and how many patients were recruited? So we aimed to recruit 30 participants for the study because it was a feasibility study. It was not powered to test differences in, pre-post intervention. We were curious to know, can we get people? What's this going to look like? What would we need if this was to go full scale? So that's that. Someone's commented that I think it would be of great benefit in a place like Nunavut, where I'm located. Yeah, we've talked a lot about this rural application when we've got this virtual care team. In theory, those team members could be anywhere. Yeah, very interesting. And I'm just reading Mark's comment here about type 2 diabetes remission, and maybe Jen's the better person to comment on this. So, change in approach creates hope for those who previously resigned to the idea that type 2 diabetes is progressive and chronic. Yeah.
Yeah, I think that your comment there, Mark, is really interesting. And while I personally haven't researched the mental health benefits of remission, I can imagine that it would be of great benefit to someone's mental health or in reducing the distress. So I think that would be an exciting approach that we could definitely give some thought to for the future. Thank you. And I think I'm just reading Nobi. Thank you. This is an awesome feasibility study. Great benefit in a place like Nunavut. Absolutely. Yes.
Yeah. And Tanya, thank you for your comment too. Let's hope for more collaborative, person-centered work in the future of healthcare. Absolutely. I think, as a registered nurse working in this team, seeing the potential, especially from that primary care perspective, so much potential here in this space. And I think, as Jen alluded to, a real appetite. People are excited about these sorts of models and approaches. Any questions?
Yep, we still have a couple more minutes for questions, so feel free to put it in the chat. Oh, will there be any follow-up with the participants? How did they do after the intervention?
So are there any follow-up with the participants, how they did it? Yeah, so that's one of the things that was identified in the interviews when I did them, was that participants, they came into the study knowing that this was going to be 8 weeks. For some of them, it was extended up to 12 weeks based on need. But after that 8 weeks, it was sort of that closure. And for many of the participants in the interviews, they expressed that they would love to have they were happy with that 8-week duration. They felt it was very intensive. They got what they needed, but they would have loved to have had a sort of bolus dose of our care coach 4 weeks down the road, 8 weeks, 12 weeks, those sorts of ideas. They spoke about that desire for sure.
And I'll add to that, I felt that as the provider, right? I felt like I was just kind of, had developed this really wonderful therapeutic relationship with a participant, And then it was like, well, see you, bye, you know, and it was, you know, rather jarring. Now, I mean, I did try and allude and did planning, but when there's only 8 sessions, it's you're getting traction, and then you're talking about offboarding already. It's so definitely some opportunities for the future to think about follow-up and offboarding in particular. Absolutely. And I see Shelley has a question. Did the health coach ever have the person's labs and medications to evaluate? No, I didn't. I didn't have anything. And actually, in the earlier sort of design process of this study, we were hoping to have connections to primary care. At least if there was any concerns, I could communicate those concerns, and we didn't throughout the duration. So that would probably be, you know, one sort of limitation, I would say, that hopefully we could work on in future iterations.
And Cheryl, to your comment, it's one thing to support short term, a whole other to know if patients were able to manage well after. Agreed that it's a whole different game of long-term support and education. And Jen and I, when we were prepping for this, we said we probably could do a whole session on the differences between education and support and what that looks like. And so for me, when I read your comment, I'm in agreement. The one thing I do want to add, though, is that Jen, in her care coach role, shared a lot of information to support people into the future. And so when I was doing the interviews, I would say to people, like, what are you sort of walking away with? And they would say, oh, I've got a whole file folder of future reading material, future referrals, things I can do, that sort of thing. But agree, it is a different approach. And thank you.
Yeah, you two are certainly getting a lot of praise, which is awesome. And I want to say thank you too, as someone with type 1 diabetes. It's been awesome getting to hear about this, and certainly agree that, you know, mental health is health and it should all kind of be combined. So that's wonderful. We are getting to the end of our hour, so I think we might need to wrap up questions if that's okay. If anyone has any outstanding questions, though, is it okay if they reach out to you two? Yeah, okay.
Absolutely.
I think.
Yes, absolutely.
All right, and I believe your emails are, yeah, right there. So feel free to take note of that if you need to reach out to them afterwards. But again, thank you both so much, Carly and Jennifer, for your wonderful presentation today. Just before we end off, I'm just going to go through a couple reminders again. So if you're interested in receiving your letter of completion for this, the evaluation and post-learning assessment will be sent to you by email by the end of tomorrow, and you'll have 1 week to complete that. And just kind of a heads up about our next Teach Educational rounds happening on November 9th. On geriatric considerations for supporting smoking cessation with older adults. And the registration link is there and open, which we'll also be sending out via email, so you can get that link there. And if you happen to miss a portion of today's presentation or want to view it again, or see a previous Teach webinar, like Carly mentioned earlier on, we do have all of our webinars archived on our website, so feel free to look there. And for now, thank you all so much for joining today and participating, and we hope you all have a great rest of your day. Thanks, everyone.
Thank you.
Thank you, everyone.
Thank you.